Good day, all, and welcome to the Teledigm Pulse podcast, your rural health matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Well, Shane, today we have on the podcast somebody who we've had a lot of history with over the years, Dave Miers from Bryan Health, the mental health department, has helped us set up a pretty impressive program over the years. So I think that we have a lot to talk about today.
Yeah, we do, Andy. I'm excited to the Teledigm Pulse to bring to the show Dr. Dave Miers, who is, I gotta tell you, it's a man that we don't have the paparazzi beating down our door right now to get a chance to see Dave on screen here. So unfortunately, we're gonna be able to keep this under wraps at least for the time being. We'll see if we've added extra security outside to make sure that we're not gonna have to deal with that without. But Dave, hey, listen, it's great to have you on the show today. And how about we just start with an introduction of who is Dr. Dave Miers, and then a little bit about the fantastic Bryan Mental Health Division.
Thank you both for having me. It's a pleasure to be on the show. I am the senior director of behavioral health services at Bryan Medical Center. I've been with the organization for 28 years. I am a suicidologist is my background. I'm a licensed therapist. One of the things that I'm invested in my career is saving lives. And, this is what I really believe in what Teledigm and this service has really helped do across the state, is save lives. And Bryan Behavioral Health Services Continuum has really grown tremendously since 1939. I think what a lot of folks don't realize, we're celebrating our 100th year this year. It's our birthday for Bryan Medical Center, not necessarily Bryan Behavioral Health Services. But in 1939, we became the first general hospital in the country to start providing behavioral health services in an acute care hospital setting. We started the first acute adult unit in a hospital, and since then we have evolved into a full continuum of services. And so we treat all ages. We have inpatient services that serve young youth, children ages 5 through 18, and we have adult inpatient units. We have a senior inpatient unit. We have partial hospitalization services where folks spend the day, go home in the evening. And then we have outpatient services, psychologists, therapists on staff. And then we have substance use services called the Independent Center, where folks where they can detox, get residential services, IOP, partial care there as well, alumni services, just a wide range of services. We have psychiatric services through Bryan Psychiatry, through Plaza West Psychiatry. We have prevention. We have intervention nurses that go into all of the hospitals to provide substance use evaluations. We have walk-in evaluations, just all kinds of different services that we're offering. But the one large service that we offer is our mental health emergency room. And that's a service that started back in the early 90s. And started as just a little room. It's really one of a kind in the country, where it's basically an emergency room within an emergency room, where folks come in the main emergency room and they say, I'm here, I'm depressed, I'm suicidal, and then they escort them back to the mental health area of the emergency room, and that's where they're seen by a mental health expert. Nurse or social worker, and they're screened. We consult with the on-call psychiatrist, and it's there that a disposition is made whether or not they should be admitted to the hospital. And then we can talk a little bit more detail about the mental health emergency room.
Yeah. Fantastic stuff. I mean, 1939, Andy, I had no idea.
I didn't have any idea it was that that long standing.
That's amazing. 1939, the first general hospital in the country to do that. So impressive stuff coming out from the Bryan Mental Health Division. And Dave, your passion for saving lives with your background so that collectively really resonates with what we're here to talk about today.
Absolutely.
In the Bryan Mental Health Triage Program, that's been really a gold standard throughout the state of Nebraska over the last, coming on 9 years now. And so that's why we're here today, in fact, right?
Yep.
To talk about the mental health triage program that was built. And sort of the genesis behind that was a guy by the name of Shannon Engler back in the day who's since retired. And in a conversation with him going back 9 years ago, and says, Shane, gosh, we have this challenge with people being transferred into the emergency department to our mental health emergency department, as described by Dave here.
Mm-hmm.
And the challenge is many of them are coming referred from other emergency departments. So it's an ED visit to a subsequent ED visit. And roughly 50% of the time, those patients were being discharged out of the emergency department. So the question was posed: is there something we could potentially do about this? And that's just kind of what we do. We take the show on the road. It's kind of what we do, right? So
Yep.
how can we? Is it possible to take the expertise in that mental health emergency department, which was to Dave's point, one of the first in the country, probably the first back in the 90s, to have that standalone mental health emergency department, and sort of plant that virtually in many other locations to facilitate that care, not only to prevent those unnecessary transfers, but then arguably a large percentage of that 50% that it was discharged back then probably would have qualified for admission had that evaluation been done in real time. And so, Dave, I'm excited to talk to you about this program today. Why don't you provide a brief overview of if somebody says, what is the mental health triage program? Maybe shed some light on that and some of the background behind that and how your expert social workers have really made a huge impact to the state of Nebraska.
Absolutely. So, as I mentioned, when it started in the early 90s, we actually only serviced the staffed the mental health emergency room just kind of like during what we call peak hours. When we ran data and said, when were we seeing the most number of folks coming through that really were asking for mental health, and then at that time it wasn't really staffed with staff basically. So
Right.
It was folks up on the inpatient units, and the emergency room would call up and say, hey, we have a patient that needs to be triaged, and we would send somebody down to the emergency room, and they would triage them and make a decision, call the psychiatrist and determine if they need to be admitted. But then it just kept growing and growing and growing, and each year I think by 10 to 15% in terms of the numbers of patients we were seeing, and so eventually we started hiring staff to actually staff the emergency room. And over the years, eventually, I just started staffing at 24 hours a day, and it grew from just this tiny little room to a large area. And then 20 years ago, when we built the new emergency room, we built this expansive mental health emergency room within an emergency room. We have 4 interview rooms. We have 2 telehealth spaces. We have 5 observation beds. We have an ECT clinic, a Spravato clinic within that area. And now we're seeing between 500 and 600 individuals in person that come in per month to see somebody as a mental health crisis. And then 60 to 80 plus telehealth consults across the state. But how that works for the mental health emergency room, so typically somebody shows up in the main ED. They're seen by the emergency room provider. The emergency room provider then at that point determines, okay, you're physically stable. There's no issues that we need to stabilize medically, but you express that you're there for mental health symptomology, and so the psychiatric provider or the emergency room provider will then say, well, I'm going to order a psychiatric consult. And so then at that point, they escort you back to the mental health area of the emergency room. And during the hours of 11 a.m. and 11 p.m., we have both social workers and nursing staff on duty. Nursing staff 24 hours a day, and so these are specially trained staff to provide these interviews. They will conduct a mental health evaluation assessment to determine if hospitalization is needed. And so then they then consult with the psychiatric provider who then determines, does this person need hospitalization, or what level of care does this person need to meet their mental health needs. And so then what we were finding, as you mentioned with our previous senior director, Shannon, years ago, is that, yeah, you're right, about 50% of those folks, did not meet that criteria. There's a strict medical criteria that must be met
Mm-hmm.
to
Sure.
to require inpatient hospitalization. And so folks will come in and we're like, well, yes, we want to help you and we're going to help you get connected to resources, but it's not going to, you don't need to be admitted to the hospital, but here's the services that we're going to get you connected to. And in many cases, we have folks that come in from around the state that drive in. And so folks were driving many hours
Right.
to see us. And so then we're connecting them back to resources in their community. So they might drive, it might be a police officer driving to our
Mhm.
emergency room and driving, 2 or 3 hours from um, Lexington, or, a couple hours from Kearney, or um, as far as, Valentine, or,
Right.
all over. And getting great care. We're giving them great care and giving them great direction, but then they're then driving back to that community with the resources that were given. And then so that's what was happening is then we reached out and said, Shane, what could we do to what's available we could do to provide the same service that would save these folks travel,
Yeah.
um, travel time.
The other thing, so my daughter dispatches 911, and one of the things I learned from her is when a county deputy has to bring somebody to Lincoln at night, they may be the only deputy on duty, leaving no deputies in the county that are on duty while they're taking care of that patient. So it's a big deal to have this service locally.
Yeah, for sure. It's not only a big deal in terms of resources for law enforcement, but it's one thing to ensure that that trip is needed
Exactly.
and it's warranted.
Yep.
And can't emphasize enough, that 2 to 3 hour trip. If I'm in a car, if I come in a rough spot into an emergency department at, let's say, 10 o'clock at night,
Mm-hmm.
and or let's say 7 o'clock at night,
Mm-hmm.
and at that time the ED provider says, Shane, I think we're going to have to send you somewhere. I think I don't know for sure, but I think you qualify for an admission, or I think it's in your best interest to be admitted to a psychiatric institution. And if that's the case, and then I'm put in a personal vehicle with Andy here, and we drive 2 hours, and I'm riding shotgun, or 3 hours, and we get to talking and chatting, and the fact is that my disposition, the likelihood of my disposition changing on that assessment when I do get to Lincoln is very good. It's very high. That you're just not going to get the same story that you got at 7 p.m. 2-3 hours later in another ED after that conversation. And so, and the unfortunate thing is, had I qualified, if the evaluation had been done in real time, and then 2-3 hours later, I'm reevaluated and now I don't qualify, that's a major issue.
Yeah.
And we're limiting the access to that care. What do you think about that, Dr. Miers?
Yeah, absolutely. And so there's the other thing I wanted to mention too is that there's oftentimes a misconception that um, let's drive to the emergency room and I'm going to be admitted, basically.
Mhm.
And we want to help. We're here to help. And yes, we want people to come. If you're in crisis, come to the emergency room. And that's our purpose, is to determine if hospitalization is needed. But that doesn't mean that it is needed. So that's when folks, are listening and they say, well, wow, why is only 50% of folks admitted? Is that we want to help folks. We're here to save lives, but hospitalization is for that acute need.
Right.
And
Sure.
um, and so we for those who need that highest level of care, they are going to be admitted. But as I mentioned, we have that whole continuum of services, and so if folks are local, then yeah, they're like, okay, we'll take advantage of that. Um, but then in these other communities, we have a whole list of services for those communities. We get them connected. But you're absolutely right. Folks who um, uh, in many cases, law enforcement, as Andy mentioned, they drive here. They're the only ones on duty. They drive here, but they want to get back as quickly as they can
Oh, sure.
Mhm.
Yeah.
to their community. But it's a process once you get here. And so in some cases, they're like, well, can we just leave them here, thinking that, well, they're going to be admitted and
Right.
they're gonna stay. It's like,
Yep.
well, we really do need you to stick around just in case. And but in some cases they do need to get back. And so then it's like, well, then and if the person's not admitted, then it's kind of working through those steps to try to help get that person transportation back to their community. So it is that's the great benefit of the telehealth program, is that it really saves um, a lot of transportation issues, but just also helps get folks connected to services even closer to their home as needed.
Mhm.
For sure. And having worked in the ED for years, I know that. Gosh, I wish I had this service back when I worked in the ED. I got to tell you, because as a whether you're an ED nurse or an ED provider, and you have these patients that come in, and certainly all providers of various types, nurses, et cetera, have some sort of background and training and education around mental health crisis, psychiatric crisis, those sorts of things. But man, in terms of delineation of admission into a psychiatric hospital or mental health institution versus not, it's a dicey proposition. In some cases, even should they be put into protective custody or not? And then
Mhm.
that's a debate oftentimes in the emergency department. Because to your point, if I'm the only deputy in the county, I might raise a question as far as whether or not you think this patient should be put into protective custody.
Mhm.
I mean, why not, right? I'm the only guy
Yeah.
here, and I don't think so. Now, ultimately, it's law enforcement's decision, right? And so you have the ED provider who's really just sort of they're in a tough spot.
They are.
The last thing they want to do is not give them the services that they need. But man, I got to tell you, it's a huge load off of that ED provider, whether it's a physician or a PA or nurse practitioner, and the nursing staff in that department, to have the expertise of the mental health social worker to come in and do that evaluation, who'd be doing the exact same evaluation right here in Lincoln, but yet
Yep.
doing that remotely in real time, and then offering that comprehensive evaluation back to that staff who could then, you know, work through that and assimilate a game plan based on what that social worker is seeing and recommending, and what the psychiatry back end's recommending. And I got to tell you, it's such a huge benefit to the patient, the family, the community, the ED
Yep.
providers. Liability. The list goes on and on and on. And at the end of the day, it's saving lives. It's improving satisfaction. Because I got to tell you, Dave, to your point, that when you got 50% of the patients being sent to you from another emergency department that are then discharged, I've been on the receiving end of some of those calls from families, and it's just not very happy with
Yeah, for
why'd you send me
sure.
there in the first place, right?
Mhm.
I mean,
Or
I gotta
yeah.
I gotta imagine, Dave, you've run into some challenges where they're a little frustrated they're not getting admitted, right?
Absolutely. Yeah. Yeah, I think, and that's what, when I was talking about kind of the misconception is that it's kind of like, well, I'm here, they sent me here, and they're thinking that, okay, they sent me here, I'm going to stay here.
Right.
And that's not always the case. And that's where, you feel bad because, but we're, I feel like, we're helping folks, we're giving them the resources, but, in their mind, they feel like that they came to be admitted, and but they just didn't meet that admission criteria.
Sure.
And but we did help them by getting them connected and so forth. And but that's the neat thing about this service. The other thing I think it's important is to really look at the data. And I was talking to emergency room provider yesterday, and really made a key point is that it made me think about some other statistics too, like in suicide prevention. If you really think about um, physician office practices, I think that the data is like 80% of you think of a primary care practice, if in a family practice doc is, let's say, they're seeing 30 patients a day, 35 patients a day that they're coming in. um, 80% of those visits have a mental health component to it. If somebody's coming in with a stomach ache or a headache or that kind of thing, well, that's a somatic symptom related to their depression or anxiety, that type of thing. And it's true with emergency room visits as well. There's just a high incidence of emergency rooms across the country, including Nebraska, where folks are coming in with mental health needs, and they don't have the expertise to deal with, to handle that. They want to help, and they do their best, but they don't have a mental health emergency room like we have here at Bryan West. And and this individual is, just tell me, well, I just feel fortunate that we have this service here, and I've had another one say, oh gosh, I wish we had that service because we have so many in other places that I've been. This is what somebody's telling me, that they have mental health patients that are lined up in their emergency rooms because they're waiting, for services. They're waiting to
Mhm.
get to be seen. And I know that's not the case everywhere, but it's just a great service because we can get that service to them and get resources to them much quicker.
Yeah, no, it makes perfect sense. In fact, I know some of the data in the pediatric population too is absolutely correlating sort of that triad, if you will, of mental health and neurology and gastroenterology all in sort of the same sphere of, and the likelihood, the numbers are actually quite shocking in terms of the patients that are making appointments for GI related issues. Could be PCP, could be gastroenterology, but at the core of the issue is actually a mental health issue. And similar data coming out on the neurology side for neuro related referrals. When at the end, the core issue is actually a mental health issue, and in some instances, mental health, but it's actually a neurology issue. But it's interesting to your point. I'm 80%, Dave, of patients in the PCP environment with an underlying mental health issue doesn't surprise me. And I think back to all the patients I see has seen over the years in the emergency department. It's probably at least that in the emergency department, outside of the acute critical care stuff.
Mhm.
Exclude that, I bet it is somewhere in that neck of the woods.
Yeah.
So it's just all the more reason to really. And it's fascinating. I'm interested in your take on this, Dave, in terms of, do you feel it's better today in terms of the stereotypical posture some folks have related to mental health issues or underlying mental health issues? In other words, is it a mental health issue at the core, and they're trying to manifest this in a GI related issue when deep down they know it is? I mean, what are your thoughts on that? Do you think it's still stereotypes, or is it better today? What are your thoughts?
Yeah, I would say that it's definitely better today. I definitely still believe there are stereotypes, stigma associated with behavioral health disorders that folks are, you know, they're afraid to speak out. They see it as a weakness to say something, but in actuality, it's a strength. I think it's important for folks to realize that that it's very treatable. That seeking out help is a great thing, and there's so many resources out there. And in fact, for instance, like depression and anxiety are the most common behavioral health disorders that we see, and they're both uh, the most treatable. And but yeah, to answer your question, I think it's becoming less and less stereotyped and stigmatized. And the one thing that a lot of things I think have helped. A couple things is that we're seeing more and more celebrities speak out.
Sure.
Like Michael Phelps. We've had couple. Well, he's an Olympian, but we've had several Olympians speak out. We had several other professional athletes. We That's one thing that we do every year for Mental Illness Awareness Week in October. We bring some folks into town with we get some grants and some different things, and we brought in Brandon Marshall last year. This year we're bringing in Shamika Holtzclaw, who's a kind of the Michael Jordan of women's basketball. She played first female to ever play in the WNBA, and won a couple national championships. And she spoke out about her bipolar and so forth. And so my point is, there's just a lot of folks speaking about their illness, letting folks know that hey, I struggle, but look, I'm managing it, and look how successful I am. The other piece I think is COVID, and with the COVID crisis that we had
Sure.
just a few years ago, we've seen a huge increase in mental health outreach, folks asking for help, and that just increased a lot of depression and anxiety across the country. And I think it just kind of helped normalize it for folks that you know what um, that isolation's not good, and it help folks talk about it and ask for help.
Yeah. Gosh, I can't agree more. And just it doesn't take a rocket scientist, I suppose, to figure out if 80% of the PCP visits have an underlying mental health issue, and it's probably that on excluding the critical care and the emergency departments, I would guess. That's purely a guess, but I bet it's not far off. It could be higher than that, actually. That's why the importance of including mental health services as part of a strategy of any type, really, whether it's an acute care strategy or ongoing primary care, or getting those resources remotely in those remote areas as much as possible. It's just all the more important. And certainly post COVID, the numbers have picked up. In fact, Dave, mental health triage, your program set a new record in March of 2025, and 87 patient encounters in March 2025 alone in rural areas across the state of Nebraska. And that's fantastic. I mean, on the one hand, it's a little shocking in terms of the number, but I got to tell you, the program offering and covering and touching that many lives in the month of March is fantastic, and such a need. And it's just impressive in terms of what you've been able to do with that program. And incidentally, some of your social workers were there when we started the program and are still there. And,
Yep.
and maybe talk a little bit about. I've always been impressed with that. It's a fantastic team, and just very impressed with that team that's still doing these consults today. Maybe shed a little light on that.
Yeah, we have a wonderful team of social workers. Our social work and therapy manager, Sarah, is outstanding. Sarah Draus. She oversees that team of social workers, and they just a great group of folks. Kate Cathy, our manager of the mental health emergency room, team of nurses that work together. Just a great cohesive group. You mentioned the 87 set a record. again, the goal is to keep folks in their home community. And, so I mentioned the 500 to 600 folks coming in person. So that particular month, we were probably closer to 500 in person, because then those 87 were seen, within their community. So we still probably still completed close to 600 assessments, but 500 of them were seen in person. 87 were seen via telehealth.
Sure.
And so that's the neat thing about it. And so, we did run some, you might have the more accurate numbers, but just my memory serves me right. We ran, just for the fun of it, our medical director, Dr. Nassim, asked us one month. He says, let's run some statistics to show how many miles we saved, folks, from driving. And if I remember right, that 1 year we saved folks, I want to say it was like 150,000 miles of driving, from just driving alone. I mean, that's just one benefit, but that's a lot of miles. But to get back to your point about the staff, they're just amazing, and that's the one thing that, this service has really, they love it. I mean, it's really engaged them, and they see the benefit of it as well. I mean, because it helps them see that, the patient is in their home. They're in their home emergency room, and they're able to connect them to their home resources right there. And if that individual does need to be admitted to the hospital, that emergency room physician. So I'm just going to pick a site here on our map. So let's say that we're talking to the St. Paul emergency room, and that emergency room physician. So what happens is that, let's say a patient is suicidal, they can walk into that emergency room, in that community, and what happens is that community emergency room will page us here in our emergency room, and then our social worker, gets that page, and then they know from that page that, oh, this is St. Paul, or this is Grand Island. So I'm going to change it. Say it's Grand Island. So the Grand Island is reaching out to us. They have an individual that needs to be triaged via telehealth. So they will go. Grand Island will send us the initial information, about that individual. We will go in and pull up Grand Island on the computer screen in one of the telehealth rooms, and that patient's right there. And so it's immediate, and we can do that same interview, same assessment that they would get right here, here in our emergency room in person, but it's still in person. It's just the only difference is what we're doing right now on the computer. And we talk, do that assessment, and then we do that same consult with the psychiatric provider. That psychiatric provider then makes that. The only difference is then that psychiatric provider gives that disposition recommendation. Then we're calling that emergency room provider and saying, this is what the psychiatrist is recommending, and then it's up to that emergency room provider then to make the decision what happens. The other difference is that, if there's a mental health inpatient unit, so let's say that the decision is to admit, then if there's a hospital closer to that community, and that emergency room provider wants to admit to that facility that's closer to that community, our goal is to keep that person closer to their family and their community, then they're going to admit to that facility. But if they want to admit here to Bryan, then they will go ahead and then transport them here to our facility. So just a great service. Social workers really have bought. I'd say the word bought into it, but there's nothing to buy into. It's just a great service. It's they see the benefit of it, and it's great patient care.
Yeah,
and that's what they like about it.
Well, you don't have that level of sustainability and that tenure with those types of providers without without being passionate about it and without buying in on
Exactly.
terms of being a part of something that's way beyond just the normal course of care, right? And if you think about it, so we've seen over 2,200 patients since the inception of the program. And to, think of the magnitude of that, you're looking at probably at least 1,000 unnecessary transfers avoided.
Oh, absolutely.
At least 1,000.
Yeah.
And so as you quantify the mileage involved in that, it is dramatic.
It is.
With some of these facilities. But 1,000 unnecessary transfers, 1,000 unnecessary irritated families and patients. It's shocking. And then, it's hard to probably put a finger on the number of lives saved throughout that process. But I guarantee you, Dave, there's absolutely been lives saved throughout this process and mitigated undesirable consequences by not receiving any sort of care or being discharged inappropriately, et cetera. Yeah, furthermore, you could quantify it in terms of overtime saved by deputies or by other services that are forced to transfer, EMS agencies, et cetera. You can also look at the number of county minutes covered by a deputy that's actually there as opposed to being detained, transferring patients. So I mean, the value proposition here is dramatic for communities and for counties. And the patients are absolutely, they're just so thankful, Dave, that you and the team have this service available. And certainly a shout out to Sarah Drous and her team. And I know Linda Kimenow was involved early on in part of the process too. It's just a fantastic team. That really, the whole team's there. Now Shannon retired, of course, but gosh, fantastic team. We're honored to be able to work with you and the team.
Well, and it's just very exciting. I mean, when you look at I just remember when we had the first site, that was exciting. And we had our first couple patients, and just seeing it work, and then it just it grew, but I'm sitting here and looking at the map that we put together, this little handout that shows the state of Nebraska, and just seeing the number of emergency rooms that we're connected to across the state. I mean, it's over 25. I mean, it's
right.
Yeah.
It's I consider that a massive outreach, and it's exciting. I mean, I think it's that's what's exciting to the social workers and the staff, is knowing that, hey, I'm coming to work today not only to impact the lives of those around Lincoln and Lancaster County, but I'm going to make an impact on the entire state today.
Oh yeah,
exactly,
for sure,
save lives. Yeah.
For sure. And I got to tell you, for what it's worth, these social workers are known. They are a known entity in these hospitals. They know them. For example, it is hey, is Luke on today?
Yeah.
I'm like, Luke who? Well, I said, oh, you know what? I don't know if he might be, but listen, these guys they're not only making a difference with the patients and the communities out there, but they are an absolute part of the team.
Absolutely.
in these communities.
Yeah.
And
they bring such expertise and peace of mind.
No, they do.
Can't
agree more. Yeah. Can't agree more. So absolutely, Dave, they're knocking it out of the park. And I got to tell you, this is one of those programs, right? That we have such a high retention rate across all of our programs, but this one in particular, which incidentally has never been shut off ever. So the program started 9 years ago, still in operation today. But this is one of those programs that if you told the emergency department staff, hey, we're shutting this off tomorrow, oh man, there'd be a revolt.
Yeah.
They're really, they don't use it, might only use it 3, 4, 5, 10 times a month, but man, it is when they need it. And they're so appreciative of it.
Yep.
So Dave, listen, hey, can't thank you enough for sharing your thoughts and your expertise with us today on the podcast. And again, back to your original passion of saving lives. You're absolutely doing that. And the team's absolutely doing that. And the state of Nebraska thanks you. And on behalf of all the rural hospitals and communities that are receiving your services, thank you. It's fantastic stuff.
Well, thank you both. And you're both saving lives by providing this.
I appreciate that. Wouldn't have it any other way, Andy. Anything else to add, Dave, on your end?
No, again, thank you both. This is a tremendous program, and we appreciate the partnership and appreciate helping the state, and anything that we can do to continue to grow and help others, let us know.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigm health.com. For more information or general inquiries, please visit teledymhealth.com.